Our next discussant will be Dr. Marston, and he's going to talk about endovenous ablation corrects the hemodynamic abnormality in patients with advanced CVI. Why you should measure the venous hemodynamics. I think I spelled that out right.
Yeah, you did. You did. So how many of you out there ever use plethysmography in evaluating your patients? Not too many. So my goal is to convince more of you that this is a worthwhile thing to do. And I have no disclosures related to this talk. We got interested in this because when endovenous ablation came out, everybody talked about closure, closure, closure. Well, you go and talk to your patient, they don't really care about that. They care if their leg feels better, and if their veins are gone and, they can get back to their lives. And we had a long history of using plethysmography, and if you have a practice where a lot of the patients come to you after having previous venous procedures and they still have symptoms, or if their symptoms don't always match, a hemodynamic measure can be really useful in sorting things out. So we started a study to look at whether endovenous ablation corrected hemodynamic abnormalities, and we also wanted to see if there's a difference in how RF versus laser did this. And we ended up publishing this in 2006, and this was all in CAP class 3 to 6 patients, and we also had some with multi-system disease that I'll talk about at the end of this. This was prospective, but it was a non-randomized two-center study in 89 limbs, and we did APG, or air plethysmography, and reflux studies before and after endovenous ablation was performed. So those of you who've never seen the APG machine, it is a cuff that is placed around the leg between the knee and the ankle. And it's a very low volume, high sensitivity cuff that can measure the volume of that segment there. The patient does various maneuvers and you can calculate data concerning the venous hemodynamics. And I would direct your attention just to the beginning section here, or measuring the venous filling index. There are ways to measure ejection fraction and the residual volume fraction, but we found that VFI was the most sensitive and useful information. And you can do this portion of the test in about 15 minutes per limb with an experienced technician performing the study. So basically the patient is in the supine position and the venous volume goes down and you reach a baseline. And then they simply stand up, keep the weight off of the leg, and you look at the curve as the volume in the leg increases. And 90% of that time and volume gives you the venous filling index. Normally that should be less than about 2 cc's per second. And Nicolaides' lab and center has done a number of interesting studies on